There are 1.9 million New Yorkers on welfare, and the state wants all of them to enroll in health maintenance organization, HMOs, by the end of the year. That may be a prescription for disaster. I'm David R. Jones, president of the Community Service Society of New York, an organization that for more than 150 years has stood up for the rights of poor people. Today's Urban Agenda will examine what the rush to enroll means to individuals and how they can best understand and master the managed care system. As our guests, we have Elisabeth Benjamin, an attorney with the Legal Aid Society in Lower Manhattan, who specializes in health and public benefits matters, and Alice Simmons, a volunteer at the Community Service Society's program to educate Medicaid patients about their choices. Ms. Benjamin, well, tell the audience about what HMOs are. What is this whole business that they're talking about enrolling so many people in?
Most people are now sort of becoming familiar in the United States and in New York about what is a health maintenance organization. It's also, these organizations are basically giant insurance companies. They're also known as managed care plans and PPOs. There's a lot of different names for them, but the idea is that there's a company, and it can be a private company or a nonprofit company, that will broker your health care. And the way they broker it is that they assign you a primary care physician, and you have to go to that primary care physician or your gatekeeper and get permission, you know, first just to see that gatekeeper, the primary care physician, for your care, and then you have to get permission to use any other services, any other health services. So you need permission to get a prescription, you need permission to go to the hospital, you need permission to get an x-ray, you need permission to go to a specialist, and so forth.
Now, they're really in a rush to enroll all the Medicaid people in this. Can they make that 1 year? Can they do all this? Can they enroll all those individuals?
They absolutely cannot put in fact, I think what we're talking about is 3 million beneficiaries that they'd like to enroll statewide in 1 year, and there's no way they can do it. The original plan was crafted in 1995. The mayor went for a waiver. He received a conditional waiver, said he didn't want that after a whole bunch. It's a long history about the struggle that we had in saying they aren't ready in 1995. And I can get into that later. The governor has a sort of more comprehensive waiver proposal, which means you have to get permission from the federal government if the state wants to waive most Medicaid beneficiaries' freedom of choice guarantee. The freedom of choice guarantee means that you can go to any doctor, any hospital, any provider that will serve a Medicaid beneficiary. So basically Medicaid recipients vote with their feet. In managed care, they would have to get into these companies and have the companies tell them where they can go for care. Now, the governor put in his proposal also in early 1995, and we're still waiting for him to, well, for the administration to show that the federal government, that New York is ready for a mandatory enrollment of all the state's Medicaid beneficiaries. What's unique about the governor's proposal is that not only does he want to put in people that are healthy, the healthy population, he also wants to put in disabled people. Now, disabled people may not be able to wait for the permission to come through to go to the hospital, to go to the specialist, to whatever. And that's what makes this waiver proposal very scary. Also, it's not clear that there's enough capacity to serve the people that need care in this system.
Ms. Simmons, you're really involved with another part of the project. Your project as a volunteer dealing with Medicaid recipients who are going to be enrolled in HMOs is as a volunteer trying to educate them. Would you tell us a little bit about the project you're working on?
Well, the Medicaid Managed Care Education Project is just that, education. Trying to educate the people on Medicaid to let them know that they do have choices, that they're not, if they go to the doctor or if they join an HMO, they're not bound to have that particular doctor. They have the right to choose. So we let them know that they have these rights. We also let them know that they must advocate for themselves. No one is allowed to say, this is what you have to do. Because you're a Medicaid recipient doesn't mean that you sit in the back of the bus.
Right.
It means that you go and you find out what the needs are for yourself and your family, and you then begin to go to each HMO. You don't just settle on the first person that comes along. So our job as volunteers and workshop leaders is Not to say that one HMO is better than the other, because we're not there for that purpose.
Right.
We're there to educate and to help them to make the choices that they need.
Have you found that this is not only a problem with Medicaid recipients? Do many people know what this whole HMO business is about? Have you had people come up?
Some of them do, and some of them are in HMOs.
Right.
You know, public assistance has been having the different HMOs come into the different centers.
Right.
And, you know, it's like Macy's and Lord & Taylor's and Bloomingdale's. Everybody's in there trying to get a piece of the rock.
Right.
So people are being informed. They're not necessarily getting all the right information, but they are being informed. There are people on HMOs who have complaints, you know, like going to the emergency room. They haven't been told what the emergency, that actual meaning. If you have a cold or a flu or a
Right.
stomach ache, don't go to the emergency room. That's not considered in the plan to be an emergency.
care. How many people do we hope to reach with this project? Do you remember? I know we were talking thousands at one
Yes,
point.
because we're
This is just a prototype.
We're in clinics. We go to settlement houses. We are in ADC, Aid to Dependent Children.
Right.
We're sort of like trying to branch out to as many places. So it's hard to keep up with the
How
number.
many, have you done some sessions already?
Yeah.
How many?
At least a half a dozen or at
And
least.
what is the reaction of the people you're working with?
It's sort of a give and take.
Yeah.
We begin to tell them about what the function is of an HMO. As Ms. Benjamin said,
Right.
you have to have a primary care physician, which you have a right to choose. You have a referral, which you must get from your primary care. You have an 800 number in the event that you can't find your primary care. You have the emergency room, which a lot of them are not totally aware of what that exactly means as far as I said before, emergency. So it's been very interesting to deal with those that know and those that don't know, because sometimes when you're in a group, some of them are very helpful to explain. I don't even have to always explain. Those that are on HMOs will sort of guide sometimes those that are not.
Ms. Benjamin, what about the type of clients who you're working with from the legal aid perspective? What kind of set of situations are they bringing out about Medicare?
Well, there was sort of the bad old days and
Right.
now.
Yes.
In the bad old days, in other words, in 1995, the state and city were very excited about this new policy agenda. They were going to do it wham, bam, thank you, ma'am. First year of 1995, by the end of the year, we're going to have 1 million people in. By the end of 1996, we're going to have 2 million in, end of story.
Right.
Well, unfortunately, what they ended up with was a disaster area. And the reason why it was a disaster area is that they went out, they allowed 22 managed care plans or 20 managed care plans to run around in the welfare centers, in Con Edison centers, on the streets, and recruit and sign up people as quickly as they could. Now, this is in 1995. So there was this real feeding frenzy and the managed care plans started telling some lies. And outright consumer fraud. They would say, your Medicaid benefits are going to end if you don't hurry up and sign up for our managed care plan. Or if you don't sign up with our plan, there's going to be no place left, which is not true. There's always going to be place, believe me. So there was a whole bunch of fraud going on, basically, and the state and city were kind of turning a blind eye to it.
Right.
So what we've been doing is, what happened is a lot of clients came to us. And what we did is we, told the city and state, look, there's a real problem out there. And they didn't believe us. So what we did is we called our own hearing. And this is a real people power story. We said,
Right.
okay, you don't believe us. We're going to do two things. First of all, we're having our own hearing. We're inviting the federal government. The federal government, of course, invited the city and state. We had 200 beneficiaries squeezed in a room, and everybody started telling their stories to this person from the federal government. And at the same time, we said, look, we're going to file a lawsuit. We sent out what's called demand letters. And between the two, I'll never forget it, because the woman from the federal government said, I have friends on public assistance, I have family on public assistance, and I've never heard the stories I've heard today. And what were the stories she was hearing? She heard one woman who was anemic and had been signed up for a managed care plan. Her child was already 1 year, and the plan still hadn't gotten that kid vaccinated. She had anemia and was pregnant again. She still hadn't had a prenatal care visit. It's been 5 months. She was homeless, and so she had been sent up to the Bronx, and her plan was out in Brooklyn. She couldn't get to the plan in Brooklyn. We heard stories of people having to travel 2 hours. You know, things that are absolutely unlawful under the current system. So basically, the city and state said, whoa, we've got to stop. And they put a ban on the HMOs coming out into the welfare centers in the October of '95. And then last year, a year later, they said, okay, we're going to let the HMOs back into the welfare center, but we're going to be auditing this. But we still have a lot of complaints. People don't know what their rights are. People are still getting hurt. People try to call up and disenroll to give improper information. But I think something else is going on. We also got a lot of media in 1995, and I think the word's out on the street that this is a option-reducing thing for Medicaid beneficiaries. At this point, there isn't the capacity in there. You have to wait a long time to get appointments, and people are really concerned that this limits their options, and they may not be able to go to their old doctor. And so what we have to do is that something may go wrong, and you don't have options, and you might get stuck with a bill. So what we need, I think, in our sort of longer struggle is a system that sets up to help people understand the system. Because how many organizations can you do as one person or as a team of volunteers? And that's why we're now calling for a client assistance program or an ombuds program.
If you would have to, you know, rate the top 3 kinds of problems that people raise with you at your sort of informational meetings, what would they be? From the floor, what would people be most concerned about?
The time span. The time that when they enroll to that first visit, when they go to the emergency room, the type of treatment, or if they're going to be treated.
At all.
At all. That has become a very important issue.
Right.
Or if they're going to stuck with a bill
Yes.
afterwards. They may get treated, but then they get the bill.
You go to the emergency room, you have a child, the child has asthma,
Right.
and your son is, and they're telling you, oh, you're not in this plan. You need to go 10 blocks away.
Right.
And my cry is, as a workshop leader, this is when you lose that quiet tone and you go to the next level.
Absolutely. Now, Ms. Benjamin, there's another thing that's going on, of course. We're suddenly hearing that some of the for-profit managed care plans are dropping out of the Medicaid market because they've squeezed the rates down so low. I've heard at least one number I was hearing that they used to be willing, the state used to be paying over $200 a month. Now it's down to the low 100s or something like that.
Well,
what is that going to mean?
What they've done, I mean, they rate the type of patient, and so they do a sort of span between anywhere from $100 to $200 or $60 to $200. They ratcheted down the rates so low. I mean, you can get New Jersey, Connecticut, all the neighboring states pay much more than New York State. This is a big problem. You can't underfund this program because one very dangerous thing happens. The HMOs say, we're not going to give the care. We're not getting paid for it. Why should we? And the state says, oh, that's the HMO's decision. So in a way, this is part of the state's agenda, is to privatize the health care. And that's sort of the background, the political background, if you will, because they just say, oh, it's the HMO's decision. And they're not out there. It's not like you have state officials out there ready to help consumers when they have a problem with their HMO saying, look, we're really not getting paid enough, so we can't give you all this care.
Well, the logic of that long term, of course, would be no care.
Right. And what's also happening is that the HMOs, what's the other sort of flip side is the HMOs aren't getting paid enough. They're fleeing the market. We'll have less primary care capacity, and the HMOs are going slow on paying their bills. So all the providers, the hospitals are upset with the HMOs. The doctors are upset with the HMOs. The HMOs are saying it's the state's fault. The consumer is, of course, the one that's left in the middle. You know, it may be the state's fault, it may be the HMO's fault, it may be the doctor's fault for charging too much to the HMO. Who knows? But this consumer is just being left to flail.
Now, there's something that our audience may have heard, which is something called the Managed Care Bill of Rights. Can you explain how that would work and who's looking at that, and will there be any teeth to something like that?
There's some teeth to that. I work with a large coalition called the New York City Task Force on Medicaid Managed Care, which is a coalition of more than 200 local community-based advocacy groups, beneficiaries, lots of folks. And the task force was one of the consumer coalitions that was at the table when we bargained for the Managed Care Bill of Rights. And what we won was the right to know. there's a lot of disclosure required. Now, each managed care plan has to tell you what benefits you have, what are their rules, everything like that. The other thing we won is a managed care plan now has to provide you specialty care services if you need it, and they have to prove that they have the capacity to do so. Another thing we won is on the emergency room standard, HMO, if that woman who has the asthma patient is a prudent layperson, I mean, not somebody who's a crazy, but you know, someone who's reasonable, really thinks her kid could have a serious, severe health problem, and if he doesn't get or she doesn't get health care right away, that HMO must pay the emergency room bill. So that's a real right that we have now, which wasn't there before, because before the HMOs would say, oh, we're not going to pay, and the hospital would bill our clients. And the last thing we got, well, two other things, is strict internal systems for problem solving, grievance procedures and UR. What we lost was external grievance procedure resolution, external problem resolution for utilization review, in other words, the kinds of services you're using. And what we lost is any kind of external entity that could help clients, like an ombuds program.
It sounds extraordinarily difficult. You're asking many, single parents who have all sorts of multiple problems, some with language problems and difficulties, all sorts of other issues, to try to advocate against a monolith. How is that going to work? Simmons, what do you think? How do people get up on their... I know it's more difficult for me as a good middle-class citizen arguing with my doctor for a different kind of, care.
Well, I think that if, what is it they say, there's unity in numbers.
Right.
The numbers have to be large enough to make a difference. So if more people begin to say, hey, this is what I need for myself, my son, my daughter, my husband, and this is what I'm going to get, then we're going to do whatever it takes. We're going to start with the Board of Health. We're going to go to New York State. We're going to go to legal aid. We're going to go to as many people as it becomes necessary. And I find that the powers that be don't like boat rocking. They sort of want a little status quo.
Right.
So the more you rock that boat, the more attention you get to what's important to you and yours. Right. There has to be a change at some point or some level.
Well, what we're hoping for is actually a legislative response, and we're working, the task force is working in coalition with other people who are having problems in managed care, i.e. the Medicare beneficiaries, the elderly people who are disabled, who are also being recruited very heavily, and commercially enrolled people like me. My employer gives me a managed care plan. And in coalition with all different kinds of payer groups, if you will, people, different kinds of beneficiaries, we've been fortunate to have Assemblyman Granis and Senator Villela put forward a bill in Albany called the Managed Care Client Assistance Program, MCAP. So think McDonald's, think MCAP. And what this does is it will help people enroll, make decisions about what's right for them, which plan's right for them, for those folks that do have choices. Many commercially enrolled people don't. Their employer just gives them one. And once they get in, helps them navigate the system. And that's a really important piece, and we're really hoping that people will come out in support of this bill.
And you think this will get the kind of broad-based support, I assume, because the HMOs are starting to take on...
well, you know what, everyone has an incentive. I mean, the HMOs would rather have some navigational source. I mean, if I was an HMO, instead of having a whole bunch of irate customers in the middle of the medical emergencies calling them up, I think they would rather have a navigational person calling, who's an external, but saying reasonably, you need to help this client, this is the problem, these are their bills, this is da-da-la-la. And that, hopefully, this external source, which the HMOs may not like this part so much, will be collecting data. So we can see the system-wide problems where the big numbers start turning out. And that's the plan.
But as you mentioned earlier in the program, if they keep squeezing the dollars down, it's all going to be a waste of time anyway, because this can't work. What is the notion that they will continue to limit rates to the extent there won't be adequate care?
Well, the Assembly has put $40 million back in the system for the managed care plans. And so there's a big sort of struggle, and the managed care plans have been doing very well in getting press coverage to their rate issue. You know, as a consumer, you know, personally, I feel like the program should be well funded, because I think that ultimately helps my clients. I don't like it when the managed care plans start making threats, and they have. They've said, well, if we don't get paid enough, we're not going to give the full benefit package to your clients. That's not acceptable to me. That should not be on the table ever. And they've made those threats to the governor,
Yes.
to the Senate, and to the Assembly. So it's not like they're pure,
Right.
you know. And
well, isn't it true that some of them have already carried those threats out, that the doctors you get if you're a Medicaid recipient is not the same as you'd get if you were a private commercial
The two-list problem. I'm really glad you brought that up.
Yes.
How does that, how does that work?
What happens is the big commercial managed care plans, the Oxfords, the U.S. Healthcares, every single one of them, in fact,
Right.
and according to Mark Green, the public advocate, did a report of this, have two lists of doctors that they use. They have a doctor list for commercially enrolled people. So I have a managed care plan, and I get one list. But I notice that my clients who are enrolled in my plan get a shorter and inferior list, so that they don't have as many doctors to choose from as I do. And what's that mean? That means longer waits for them. That means a little harder to get care for them. It means maybe longer waits to get into the hospital for elective surgeries. It's a real problem. And besides that, it's illegal. I mean, there is the Title VI of the Civil Rights Act.
Right.
I mean, you're not allowed to discriminate against people on the basis of them getting federal Medicaid dollars. That's not allowed. We've raised this issue over and over again with the state, with the federal government, and the HMOs. And they say that they're working on some kind of compromise, but since it's all secret, these negotiations, and advocates and beneficiaries are not allowed to know what's really going on, we have no idea what solution they're going to slap down on people. I mean, so far the solution's not so good. You have two lists.
Right. Simmons, do you see any of that when you hear from clients about their concern about who their doctors are going to be?
Yes.
Yeah, that's coming through.
In many instances, they're given a doctor.
Whether they like it or not.
They don't have, well, they don't know they have a choice.
Right.
So they have Medicaid, they join an HMO. When they go for the first visit, they're told that Dr. Smith is your doctor. And if you're not aware that you can have someone else or that you can have another doctor, you take Dr. Smith.
The law guarantees everybody to have a right to choose of at least 3 doctors. So every client, every person who enrolls in managed care has the right to choose from among 3 doctors.
Well, this is the one thing about this handbook that
please.
I like, is the fact that on the back it gives you the Bill of Rights for the patient.
Right.
And at each workshop, we give these books out. And they're in English, also we have them in Spanish. And I find that they're very helpful because when they go home, there are grievance outlines for letters here in this book.
Put them together.
There's the difference between what Medicaid is when you're not in an HMO, and then it tells what it's like when you're in an HMO.
Right.
So they have sort of a balance. They can tell the difference between the two. So we go through the workshop, give them this information, and then we give them the handbook so that they can also look into it and become more educated.
And if you're not in a Medicaid HMO, that's an excellent book if you're in a Medicaid HMO. But if you want to know what your new rights are under the Bill of Rights that was passed last summer by the state legislature, and you're in a commercial or if you're in a Medicaid HMO, the general Bill of Rights is outlined in this little handout that the Citizen Action puts out.
Ms. Benjamin, what about the rest of the country? It's not only New York. I mean, we do sometimes get a little bit of tunnel vision here. What's happening in the rest of the country on Medicaid recipients and HMOs?
There's very different things happening depending on where you are. Recently, Los Angeles has been having a total disaster. They've shut down one of the major HMOs in LA County. They've had terrible problems with enrollment. They closed down the broker in LA County. There's been terrible disasters with this attempt to throw Medicaid beneficiaries into managed care. So that's sort of the disaster story. Is California, Tennessee also had a disaster. Other states have done it right. Minnesota, Michigan, some of these states in the Midwest are working, and they've set up consumer help programs. They've set up navigational assistance because the clients just don't know how to deal with this whole new system of health care because it's very confusing for people.
Now, what happens, there's a big welfare reform issue going, and literally we think we may have hundreds of thousands of people who lose their welfare benefits. Will they lose their Medicaid benefits then? And what happens then?
Under the federal law, Medicaid's held harmless.
Okay.
But it really depends on what they do in Albany. this year, and it's unclear what they're going to do. I mean, it seems to me that everybody's saying time limits are on the tables. Even the Assembly Democrats, the good guys, are saying, you know, from our perspective, that 5 years maximum lifetime, you know, welfare payments. And there's a lot of problems for people who are immigrants, and that's gonna hurt. Some people are gonna be off.
Now,
the
when
system.
the 5 years is up under the welfare bill, does that mean you lose your Medicaid as well?
It could in New York State. We don't know what, because New York State has its own Medicaid program. They won't be, no matter what, they won't be federally paid for. But they could pay for it under the state's Medicaid program. And New York has been traditionally very generous.
Now, there's some discussion, I hear, that there potentially may be an HMO program for the uninsured. Is that likely? I mean, we have an enormous number of uninsured in the city of New York, and now, of course, with public hospitals under siege, what's going to happen?
Well, I know that Mayor Giuliani did put out a proposal, the Thorpe Commission and the proposal, and it's so funny, they put that out and suddenly they just said nothing. So I don't know what they're planning on doing. I understand the HHC, as part of this waiver package, wants to work with small businesses to get managed care options open up for folks. I hope so. The other place where uninsured can get managed care coverage is through the CHIP program, the Child Health Insurance Program.
Well, would you explain that?
Sure. If you have children who are less than age 19 who want to get health, and you don't qualify for Medicaid, you and your children don't qualify for Medicaid, for a small, either for free or for a very small fee, you can get full inpatient health coverage and outpatient health coverage, Medicaid benefits, or not Medicaid, but, you know, health insurance
Where would
coverage.
people find about
New York
that?
City Department of Health. The Child Health Insurance Program. I wish I brought the phone number with me. I didn't, but
We'll get it
we
from
can.
Probably in here.
It's probably in there.
It's a great program, and you know, sign up quickly because I'm not sure if there's going to be enough spaces.
Thank you both. Government's rush to enroll Medicaid beneficiaries without first laying the educational groundwork could lead to hardship or even loss of life. Unless individuals understand exactly how to access their health care before a crisis arises, this plan, like others hastily put out by government, will lead to tragedy for families and unwanted newspaper headlines for the bureaucracy. The Community Service Society is doing its share, but its workshops will reach 4,000 individuals, only a fraction of those affected. It's the responsibility of government to see that all Medicaid beneficiaries are educated about this vital issue, and then provide the oversight to make sure the HMOs are delivering their promises. This is David R. Jones. Thanks for watching The Urban Agenda.
To comment on the Urban Agenda or for more information on CSS, contact Community Service Society of New York, 105 East 22nd Street, New York, New York, 10010. Area code 212-254-8900.